young adults with diabetes. This is what I have been telling you from the beginning. The clinician's inertia, the physician's inertia is the cause. Like if you take this, the causes, the 55.8% is because of physician's inertia, and 44.6% is the patient's awareness, and 45.8% the misconceptions of about statins. This is become a menace for us actually. Couple of years ago, and we had the social media loaded with this particular the anti campaign against the statins. I don't know how it came. Like majority of the doctors they got confused, and the message, the inference of the social media message was just that the statin is pharma based product. It's only to enrich the doctors. Please don't ever use statins. This was the core message which was circulated in the social media, and it was published in the papers also, the newspapers in the United States of America, in the Canada, and even the United States, and even the European Union also started believing in that, and so many deaths have taken place just because the patients just believed this particular false campaign against the malicious campaign against the statins. They stopped statins they abruptly, and they landed up in this particular cardiovascular disease events, and thousands of people died very miserably because of this. So be cautious about that. Don't believe in the social media. Social media gives you sometimes the good news, sometimes the right news in the form of a bad news. So never ever believe in that. Okay, you get clarification from your own doctor. And one more take home message I would like to give is, see, once you start a statin, you can never stop it. You have to use it for lifetime. There is no way to stop a statin. It is a marathon run. You should continue that to enjoy the fruits of that particular statin. You should continue it to prevent the complications, like the very particularly the atherosclerotic cardiovascular disease. And the compliance was a big issue. 41% said compliance, and 38.5% said adverse events, the myalgia, the statin intolerance, and all okay. See, I said, once the patient gets myalgia, you simply ask the patient to stop statin for 1 week. If it is because of statin, the myalgia, the myopathy or myositis, whatever it may be, the rhabdomyolysis, the acute renal shutdown, and the sudden deaths, these are all the complications. I am telling you the natural course of the complications of this particular rare and remote complication of this particular statin is the rhabdomyolysis, which leads to acute kidney injury and death. So before that, the patient complains of the muscle aches, the body aches, and if it is because of statin, you stop the statin for 1 week. The patient must be all right. If the patient says still I have got this muscle aches and all, you should go for the evaluating with the serum creatine phosphokinase. If it is very much elevated, then you should consider the statin as the culprit, or else you don't need to. And again you should start the statin, and again if the patient gets the same similar episode, you have to change this particular statin. Suppose you are using rosuvastatin, the patient complains of this particular thing, you can go to atorvastatin, or the patient is on atorvastatin not tolerating, again you go to rosuvastatin. The stop and start technique that gives you the clue whether the culprit is the statin or the patient's inertia or non-compliance of the patients. That is what is very important, because we rarely see this myalgia and statin intolerance. So a total 55.8% 8% of the HCPs they considered that the physician's inertia limits the effective use of statins amongst the young adults with the diabetes. And now you can see for patients with diabetes aged around 20 to 39 years with additional atherosclerotic cardiovascular disease risk factors, it may be reasonable to initiate statin therapy in addition to lifestyle therapy. I said lifestyle therapy is a cornerstone in managing diabetes, hypertension, and dyslipidemia and obesity. So, for patients with diabetes aged around 40 to 75% years without atherosclerotic cardiovascular disease, use moderate intensity statin therapy in addition to lifestyle therapy. And in patients with diabetes at higher risk, especially those with multiple atherosclerotic cardiovascular risk factors, the risk factor are the aged around 50 to 70 years, it is reasonable to use high intensity statin therapy. The ADA 2022 guidelines and it recommended for early initiation of statin therapy with optimal intensity for better prevention of atherosclerotic cardiovascular, which is a take-home message. So the ADA publishes the guidelines year-wise. So the first issue of the diabetes care, the diabetes care and the diabetes are the official journals of the American Diabetes Association. So diabetes care, the January edition that include that gives you the only the guidelines for that particular year. So that is released in the net even prior to that, like in the month of December it releases, but it officially declares the guidelines, the recommendations, the standard care of the medical practice with regards to diabetes that gets released in the month of January edition of the diabetes care. And the Rose Care study. So the methodology of the Rose Care study is it's a retrospective, non-comparative, multi-centric real-world survey. The medical records of 7,295 patients who had received treatment with rosuvastatin 5 mg, 10 mg, 20 and 40 and rosuvastatin based fixed dose combinations, that is FDCs with ezetimibe or aspirin or fenofibrate or vitamin D or the DAPT, that is a dual antiplatelet therapy, or clopidogrel as a lipid lowering therapy for primary and secondary prevention of cardiovascular events in type 2 diabetes mellitus in diabetes care clinic settings were recorded. The data were collected from the medical records of the clinics, the EMRs, the hospitals across the 450 study sites in our country. The rosuvastatin and the combination of therapy in type 2 diabetes, the Indian real world study. So again, coming to the Rose case study, the potential utility of rosuvastatin as monotherapy. Majority of the patients with type 2 diabetes mellitus, that is 85.6%, received lipid lowering therapy for primary prevention of cardiovascular events, and majority of the patients, more than 88% of the rosuvastatin 10 mg or 20 mg for primary prevention of the cardiovascular events. These are the inferences from the Rose case study. That's what. The significant reductions in the LDL-C, total cholesterol, than the triglycerides along with the improvement of HDL-C. That's what I said. The best part of rosuvastatin is it doesn't alone reduce the LDL-C. It reduces the total the triglycerides along with the improvements in that is increase in the HDL-C. If you take this the parameters as HDL-C and the LDL-C and the total glycerides and the triglycerides, the four parameters you take, you can clearly see from the baseline to the follow up and then the mean change, the p-value is always, you can clearly see that it is less than 0.001%. That is statistically very significant. And you come to this physician global evaluation of the tolerability. The physician global evaluation of efficacy and tolerability showed a majority of the patients on good to excellent scale, that is 84.9% and 84.5% respectively. You can see this the cartoon. You can see that the dark blue is excellent and the violet is very good, and next is good, and yellow is average, and red is fair. And with regards to efficacy on the left hand side, you can see that there is 10.9% said it is excellent, and 28.7 said it is very good, and 45.3 said it's good, and 12.8 said average, and 2.3% said fair. So when you come to this particular aspect of safety of this particular the rosuvastatin, they said the 11.7% said it is excellent, 27.4 said it is very good, and 45.4% said good, and 12.8% said average, and 2.7% said fair. So this shows the efficacy as well as the safety of this particular molecule, the rosuvastatin. And probably coming to my last slide, the take home message, the summary. The management of diabetes and its complications in India is a huge challenge. We need to accept the challenge as clinicians, as physicians, as diabetologists, as endocrinologists, as cardiologists. Everybody should get involved in this challenge. We must take up the challenge, and we should try to overcome the hurdles, and we should try to overcome this crisis actually. So, or else the patients, they miserably land up in the atherosclerotic cardiovascular diseases. They may die, they may just get into the hospital, and they may be hospitalized for thrombolysis or percutaneous coronary intervention or coronary artery bypass graft, which is a big economical burden and menace to a country like still ours is a developing country like our country. And the patients with diabetes mellitus have a higher risk of cardiovascular disease. Almost the incidence of cardiovascular disease in type 2 diabetes is around some 86%. And initiate statin therapy in diabetic patients aged around 40 to 75% years and not having atherosclerotic cardiovascular disease. This is very important. So, in the absence of atherosclerotic cardiovascular disease, you should initiate a statin in patients suffering from type 2 diabetes mellitus aged around 40 to 75, irrespective of the even the baseline LDLC also. Among the people with diabetes aged around 20 to 39 years having additional atherosclerotic cardiovascular risk factors like the early initiation of statin therapy will help reduce CVD risk, and it's recommended to initiate moderate intensity statins and assess every 3 months for tolerance and compliance to the therapy. And for early initiation approach, the rosuvastatin should be preferred over the statins. And rosuvastatin is an effective and safe lipid lowering effect for both primary and secondary prevention of cardiovascular events in patients with type 2 diabetes mellitus. And I would like to once again remind you that the rosuvastatin is the only molecule that doesn't only reduce the LDLC, doesn't only reduce the total glycerides, doesn't only reduce this particular the triglycerides, it also increases the HDL. See, these are all the integral parts. Earlier, the typical Indian dyslipidemia around 20 to 30 years ago, it was only the elevation of triglycerides and with low HDL. Low HDL and high triglycerides was defined as the Indian type of typical dyslipidemia, and now that it is changed, like Western scenario, they find only the increased levels of the LDLC. They have normal triglycerides and they have got normal HDLC, but whereas we have got the all the problems, the triad of problems, like the high LDLC we are seeing, and the high triglycerides we are seeing, and we are seeing the the HDL. So I request my participants, my fellow colleagues, my dear professional colleagues, you don't alone stop with rosuvastatin. Be bold enough, if at all there is increase in the triglycerides, you go for a combination. They have got a wonderful combination like rosuvastatin 10 milligram with 160 milligram of fenofibrate. My favorite brand is this particular rosuvastatin with 20 milligram, that is with 20 milligram of rosuvastatin, the 160 milligram of this particular the fenofibrate, and they have got wonderful combinations with this particular either you take rosuvastatin with DAPT, that is rosuvastatin 10 milligram and 75 milligram of this particular aspirin and 75 milligram of clopidogrel, and 20 milligram of rosuvastatin with 75 milligram of aspirin and 75 milligram of this particular clopidogrel. And I always ask you, even you start with a low dose like 10 milligram of rosuvastatin with the complicated combinations what all I said, you slowly try to escalate to 20 milligram. The optimal dose of rosuvastatin is all the time, the desirable dose is, the minimum is 20, the maximum is 40 milligram. Don't be scared to initiate a statin, like you get scared to initiate insulin. It doesn't trouble your patient. You are going to save many lives. And with that, thank you so much for patient listening. And if at all there are any questions, I would like to clarify the questions. Just feel free to ask me the questions. You can put it in the chat box. And thank you so much.